Welcome to our last session in our series of managing weights in perimenopause and menopause. So my name is Dr. Nicoletta Mabena. For those who don't know me, I'm a medical doctor, epidemiologist, and my interest is really in supporting women in midlife to have health, wellness, and quality of life filled with joy and vitality. Just a few definitions. Perimenopause is the transition phase leading up to menopause, when cycles become erratic, irregular, and symptoms begin to show. And these symptoms can range from mood swings to hot flashes, rashes, skin itchiness, vaginal dryness, changes in libido, and even sleep problems. So, you often hear some people complaining of joint pains, muscle problems, weight gain. This is what we're discussing today. And the weight gain is especially around the abdominal area and the visceral areas. So the list is quite long in terms of the symptoms. But if you pay close attention, you will notice the changes, even if they are subtle. And this can start even in your 30s. And then the menopause itself, which is a 12-month mark without a menstrual period. Then we get post-menopause. Then when we say you have premature menopause, it's when you have menopause before the age of 40. Early menopause is between 40 and 44. And then if you reach the age of 55 now and you're still having regular periods, we begin to monitor you closely as we try to understand if there are any underlying causes. So some women think they don't need to hear about perimenopause or menopause, be involved in these discussions. However, if you are a biological woman and you're over 40, there's a high chance you are in perimenopause. Even if you don't feel horrible as the next woman, your ovaries will eventually not function as they did before, and you will hit menopause. So every woman's story is different. So hence we need to respect each other, need to understand each other, and help each other as much as we can. As we grow older, life shifts in ways we knew would happen, but we didn't realize that they would come this fast, right? So society looks at us differently, being called moms or ambuya in Zimbabwe, that's what we're called now, or even gogo. It's no longer sisi or sister. Children also now begin to orbit in their own circles. It's no longer with us. So it just got me thinking that as a woman grows older, she has to learn to re-anchor, to build a life that holds herself at the center, not her roles, not her titles or responsibilities. For so many women, especially in midlife and beyond, loneliness doesn't come from being alone. It comes from years of focusing on everyone else, your children, your partner, your community, everything else, even your work, until one day you look up and realize that, you never learned how to choose yourself. So before we get into today's topic, I want to talk about friendship in midlife. Friendship or community is actually not a luxury in later life. It is a protective factor, It shields us from loneliness and just being alone and having someone to interact with in those days where our children have gone, friends may have passed away, or we are just in our households by ourselves. Even if you've got a partner, sometimes you're not in sync and it becomes very lonely. So even if it's just one person, it can make a difference between shrinking and flourishing. So whether it's a church group, a walking club, a book circle, anything, even a trusted friend that you just talk to once a month, these connections become the emotional anchor of our later years. And woven through all this is something many women never get taught. That's self-love. And that self-love is not actually indulgence, but it is survival. So it is the foundation of joy, resilience, and dignity in the decades ahead. I recently went on a girls' trip with women I was in school with 34 years ago. I hadn't seen these women since I was 16 years. We were just celebrating ourselves as we turned 50. So even though we have different paths, we shared a week together with these awesome women. It was quite liberating to remember that we were once young. We shared childhood stories. We sang every song that we could remember from high school. We acknowledged our successes and our failures throughout the years. The laughter was really contagious. We parasailed, jet skied, went on Bali swings, got a bit seasick, snorkeled, and we felt our joy pegs and the like. But it was a 50th celebration that was packed with activity. So it just reminded me that, age isn't nothing but a number. Though our bodies are 50 and the joints can be shaken, our spirits are definitely 25. So the trip showed me that friendships change as we grow older. What it looked like when we were 16 is definitely different in midlife. As we grow older, friendships become less about intensity and more about presence, just being present. You don't need to pour out all your entire life story to feel connected. You don't need to expose every wound to feel close to someone. You don't need to overshare to be loved. So midlife friendships thrive on shared activities, spiritual connections. Those are the churches, prayer groups, choirs. There's lightness and there's laughter. And again, that presence of just being there without pressure. So these are quiet but strong friendships. They don't demand emotional labor, therefore no emotional exhaustion. Connections are without overwhelm and don't drain you. They don't require you to perform. Belonging without burden. Unlike when we're younger, where there was a burden, where I need to perform, I need to keep up with the Kardashians or whoever it is. It simply allows you to be you. So it's some form of self-love. So today I want to ask you, who are the people you truly excel with? It may be your partner, it may be a friend, it may be community, it may be church going, whatever it is, you have to have something. How can you create a life where friendships are not accidental, but are intentional? It may be a male, it may be a female, it doesn't really matter, but that friendship is intentional. Are you waiting for others to reach out, or can you be the one who initiates connection? Have you allowed yourself to drift into loneliness because you're too busy caring for everyone else? Remember, you need to also focus on yourself. What do you want? What brings you joy and what brings you happiness? This is what helps us move through midlife. So a lot of us really are skeptical about friendships because of gossip, mistrust, dishonesty, and online you'll see all these things. However, you can have a friendship where you share what feels right. You keep what feels private. You enjoy each other's company. You don't have to feel guilty for having boundaries. This is still a friendship. You do not necessarily have to share, overshare, say things that you feel are private. They are your story. And sometimes that one steady friend, the one you walk with, pray with, laugh with, or sit next to in church, is the difference between loneliness and feeling seen. I see a lot of women or people in general who die alone in their homes and found after years. How is that possible? We need to do better, ladies. So anyway, before I introduce our guest speaker, just a reminder that this is an informal webinar conversation, which is relaxed and designed to foster genuine interactions. Keep your mics and cameras switched off. Please use the chat to post questions and comments, and we can get to them at the end of the session. And of course, please use emojis to show your reactions. Also suggest some topics or issues that you want us to tackle. So thank you to everyone who's completed our anonymous survey to understand the real experiences of African women navigating midlife changes. If you still want to participate, it's still open. I'm going to keep it open until the end of June, and then I'll just do an analysis and then tell everybody once I've done that. So please forward these webinar registrations to, or my YouTube channel, to women over 40, because as I said, those who are in the early 40s think this is not for them, but actually they're the ones who need this information to work with themselves as they build towards getting into menopause. As mentioned, this is our last session on weight management. In 2 weeks' time, we'll be talking about menopause hormone therapy. So really, this is not the last webinar, it's just the last session in weight management. And then I will also bring a doctor who will talk about your first perimenopause or menopause consultation with a GP or nurse. How do you advocate for yourself? Because like myself, I had so many consultations with doctors before I could even figure out that I was in perimenopause. So we'll also dig into genitourinary tract issues, UTIs, vaginal dryness, sexual libido, and I also want us to get a perspective of the males on sexual function as we get older. Maybe as women, we can better understand erectile dysfunction and why rising to the occasion is now a mission for our partners. I mean, they also have their own issues. And most of the time, it then is blamed on us. And they tell us that we're in menopause, hence they are failing to, but actually it's biological. We'll then move on to perimenopause and relationships. And, your mother-daughter relationships, mother-son, and the big one, being a mother-in-law. Why do we end up being the monster-in-law we hated and despised when we were younger? We have put effort into not being the monster-in-law. What can we do? What's going on? Is it the moods? What is it? And how can we navigate this space? Let's try and change the narratives. Today, we are going to understand why your doctor won't always reach for the prescription pad for our, weight management. So again, we've got Dr. Wimbai, who will help us understand how to manage our weight during perimenopause and menopause. She's a bariatric physician with 23 years of clinical experience, includes a decade of adult weight and metabolic disease management. She's a clinician who champions a new compassionate standard of care. She's someone who builds powerful patient-led partnerships between individuals and clinical teams. She's the founder of Maitano, a doctor-led digital platform offering current evidence-based advice and non-surgical treatment options for people that would want to manage their weight. So, hi, Wimbai. How are you doing? Welcome back after a long hiatus.
Hi, Nico. How are you doing?
I'm good, thank you. We've talked a lot about weight management, right? Today, we just want to sum it up and help people to understand a few things, ladies, so that when they go to a consultation, they actually know what to expect. So what should a woman expect during a weight management consultation with a doctor in midlife?
So before we jump into all that, I think if we approach this session, I like the little conversation you had at the start. I like this particular section because we're now talking more about focusing on oneself, which is what I would like you to keep in mind as we talk about everything. So the focus is on you. And then the other thing, you spoke about friendships, but then what I needed to take away from that was partnerships, because we want you to create partnerships with your teams, your clinical teams. So I want you to hold on to those two concepts always, and certainly for the conversation today. So I think the first question you broached is what to expect in a consultation, and that's obviously something that's exciting to me because that's what keeps me going every morning. So I think when it comes to a weight management consultation, I would like you to, as you book it and plan it and go through it, figure out that this is a very comprehensive approach to your health. So you will touch on all aspects of your health because your weight is the center, your body management is the center of a lot of things regarding our health. So sometimes people are surprised by the things we end up talking about. Or spending hours talking about, and they thought, okay, I'm just going to get, weighed and be told this is what I need to do. So it's the preparation and conceptualization in your head that this is going to be a very broad talk about all areas of your health and your body. So that's the first way to look at it. And it's also not a quick consultation. It's naturally, you can imagine there's a lot to touch on. There's a lot of historical context to build. There's a lot of present person to deal with, and then expectations both on yourself as and then your clinical team, what we're trying to also build as your expectations and results for what is appropriate for you. So certainly for my practice, our assessments tend to run over not one session, so maybe about 2 or 3 or more, depending on what's happening with this patient. But I sort of approach the first consultation that we have, I think, is the most important. It sets the stage for the partnership that we then build. And I find that a lot of successful patients, we've had a successful initial consultation. So the preparation in what to expect in terms of timing, how long it takes, what sort of areas we'll be approaching is important. And then also expect to be very open and vulnerable. A lot of these conversations do become quite emotional, you'll find, because like I mentioned, there's a lot. So even if you just look at the aspect of weight, it tends to be quite emotive for a lot of women for a lot of reasons. And it's something that women have been, so we talk about women in the perimenopause, for example, they've been dealing with this for many years of their lives. I think people will tell you, I've started noticing or talking about my weight since I was about 10. This woman who is 45, 46, who's had many versions of themselves through their teens, preteens, teens, childbearing age, and now coming to the end of it. So, and then also obviously there's, I mentioned that it touches all areas of your life. And there's also, in terms of the emotional and psychological impact on our health, how we feel about our bodies also means a lot to us, about our confidence, about how we perceive ourselves in the world, the confidence to pursue the things that we need. You'll be surprised how much of that sometimes is tied to people's weight. So it's always, I always feel very privileged when I sit in front of people and we get to a point where they're able to unearth and dig out all these areas and how it affects them individually. So be prepared as well to touch on emotional aspects that you probably are not expecting to dig up when you think I'm just going to talk about, I'm going to be weighed and I'll be given some pills or something. So we'll start obviously by taking a history, and I mean, I won't go into all of it, but what we're trying to do is ascertain your expectations, what's brought you on today, what's led to this desire to take control of your weight. We then want to do obviously the clinical bits. We want to know how the weight that you have has affected your body as a whole. So we'll touch, it's really a head to toe situation. We're going head to toe, inside, outside. We're talking about skin, we're talking about the bowels, we're talking about the heart, we're talking about psychological impact, we're talking about social impact, all those things. So we touch on all those areas I mean, it's not going to be tick box one way or the other, but then we, depending obviously on who's in front of you and how things are going, but we will touch on these areas. And then we move on to the physical side. Obviously we want to sort of know, we do want to know your weight, we want to know your height, but it's not just about weight, which is something that I like to make very clear from the start. And even as we're talking now, we want to talk about how the weight has impacted on your health always. So I want that to be front and center of the consultation. And what we're trying to achieve and the expectations we set and the successes we get are based on real tangible things, not just weight. So the weight, I always say, will follow. When we get it right, the weight will fall off. So I don't even want to worry about that. And I find that after some time, after my patients get sort of acclimatized to what we're doing, and they get it, and when they eventually get it, they'll come. They don't even talk about the weight. They don't even talk about the scale. They don't even talk about all that. It's, oh, you won't believe what happened to me this week. I slept better. I spoke to a friend and I was advising them on this, that, and so. Or I used to struggle with this, or I moved, I've increased my exercise from the 30-minute session a day, every other day. Can you believe it or not? I did 40 minutes every day, Monday to Friday. So we start now looking at my blood pressure has been normal. So I then enjoy those conversations because those are meaningful changes to people's lives. And this is what keeps us going. This is what kills us. This is what affects us.
Yeah.
So we do all that. Obviously, we can't ignore the physical side of things. And then we also now prepare for the metabolic assessment. So we do bloods and all those things, which is another session. So this leads us on to the next session when we now discuss results and what we're going to do. And then we also, the assessment, we do a massive part of this is a nutritional assessment, which again, is a constant assessment, but obviously we need to know where we're starting from. We're all different. We all have different concerns. We all have different eating behaviors, eating habits, eating desires, preferences. You've got some people who are snackers, grazers. You've got some people who are busy on their organic front. There's people who believe in larger portions or fighting larger portions. People who prefer maybe a more plant-based diet. So you want to know all these things before you make any recommendations that make sense for each person. So we don't give a plan. There's no plan for everyone. It's a prescription, a nutrition prescription, which is specific to each individual based on what we've done. So this assessment that we do, obviously we talk about it a little bit in the session, but then we then build on it over the next few weeks of assessment where, depending on what the person prefers, we can do a photo-based journal, or they do one where they're actually filling into an app and all that. It just depends on, but I find a photo-based journal the most impactful for me and for the patients, and especially now we've got our mobile phones with us all the time. And I always ask them to keep their own records of where this is going, because then it shows them where they've been. It shows them when the change happened. It shows them when it all started making sense. And then if things, as they do in life, go wrong, they know where things change, what changed. What if I look at my diet now for the next 2 weeks, where was I at that time when I felt I was doing well? And it makes so much sense. Then we do the nutritional assessment. We do a review of medications, which is also quite important. We do a sexual and a menstrual history assessment, which is another big deal. And then we also want to look at social considerations. So, what is the home life like? How do you manage your meals, food, finances, and things like that? All those things come into play. So these are just some of the areas that we then look at. So
yeah, that's quite nice. I love it because it's quite holistic, and also not focusing on the weight or the scale. I think that's very good, because then you see the impact of it on your different aspects of your life, and then the journal. Can you just give us an idea of what a journal looks like, a photo journal? What am I taking? A finger or my whole body? Am I naked?
So photo journal. So there's two ways we use the photo journal, and so the only one we actually three ways. We do a movement journal. We can do a movement journal. We can do a food and nutrition journal, and then you also do a body composition journal. So the body composition journal, I don't want to see. I don't want you sharing with us. But at the beginning, I always encourage people to take photos. I mean, sometimes when people are most unhappy with their bodies, the last thing they want is a photo.
Yeah.
So you find that at the beginning of these journeys, people are so drawn into themselves. They're so not willing to even imagine that things could change. So you almost have to convince them to take pictures for themselves, right? There's a series of photos that I encourage everyone to take, and then just store them away, put them on your Dropbox or wherever it is, and just
look at them.
Yeah, forget about them. It's not for us to see. I've got my measurements, my clinical measurements that I do. So that's the body composition journal photos that I always do a series that we do. And then, so usually people then come out themselves. I don't even ask them, well, whatever happened to those photos? They come, this is what happened. I pulled those photos out. Oh, can you believe this? Oh my God, I couldn't believe it. It marks another turning point of their care. So at the beginning, what's really important to me is the food and nutrition journal. So that's what I'm saying. So that's what you're asking, what does that look like? What I have a statement. I think if there's any of my patients on here, they'll know: snap and go. People are quite hesitant at the start to share what they're eating. So you find if we sat down in a consultation and asked me, oh, please, Nikki, can you tell me about your diet? People think that there's things that you want to hear as their doctor.
Yeah.
There's things that you want to see. And so you never really get a good picture. So you don't get even an idea of what their pattern of eating is, what time are they eating, how do they eat, how do they serve their food, what foods do they like, how, all these preferences don't show up in such a conversation. So once we get over the first, it really takes maybe about the first week or two. So when you had the first review after the first, after they do their first full week of a journal, people then sort of a bit more relaxed about it, and they realize, oh, you know what, no one is doing this because they want to judge my food presentation, because they want to, but truly we are getting an assessment of, okay, so then we start now getting goals. So it might be this week, what I would like. So obviously our follow-ups are a lot more consistent and a lot more frequent at the beginning, as because the idea is all this, we're trying to establish habits that are sustainable and meaningful at the beginning, so that, and obviously getting to know each other and our personal needs. So you'll find somebody, some people, they want to eat at 7 o'clock in the morning. The moment they wake up, they want to have something to eat. They want to have something when they get to work. They want, or somebody wants to wait until maybe midday to start eating. Someone wants to have little frequent snacks every 2 hours or whatever it is. All these things mean different things to. So when people then tell you, oh, I'm on an intermittent fast, and I lost weight, or a juice fast or whatever, it then means absolutely nothing, because we're all different and we all prefer things. Okay. So then we start giving targeted advice based on what we're finding, and then we make changes. And so it's not going to be one massive, another thing is, we'll never say don't eat this or don't eat that or whatever it is. There is no food that is bad, there's no food that is good. These are all food is a combination of different macronutrients and nutrient and minerals and all those things. So it's just the spread and how you choose to consume them, how much you choose to consume of this one, at what time, and how you spread them out during a day. So there's no bad food, there's no good food, there's no, how dare you eat that or whatever it is. It's just, okay, you know what, so this person likes to eat this. How can we make it more meaningful and healthy and help you to achieve your goals while you eat that? Okay, add this. I always do a more is more. So I would rather add things than take things away from people's diets. So, and that makes sense. It sort of makes sense in the grand scheme of things. So we do that, but it's incremental steps to get to. So it's not going to be, oh, we'll be done in a week or two, and then there you go, voila, you've got everything that you're eating.
Okay. That's quite interesting. Eh? So what are the most important questions women should ask during a consultation? Because there's a lot that we've talked about, but I think let's just talk about 3 things that they should ask definitely in a consultation.
Okay. So I think it starts from figuring out what you want to achieve at the beginning before you come to your consultation. So as you open up to whoever you're talking to, and hopefully they are starting from that point with you as well, of why you are there with them. So if you know your why, so it could be, so maybe people don't just show up because they think they're fat, because you probably have had the weight that you have for years. But something triggers you wanting to change that weight. So that's usually a good place to start. So if you know what that trigger is, if you come to your consultation and you ask things like, how can you help? How can I lower my blood pressure? How can I move more with my children? How can I've got my grandkids with me and I realized I couldn't keep up with them, or I'm not interested in my husband anymore at the moment. How do I improve that relationship? Or I'm struggling with work, I'm doing this, how do I, or what are realistic expectations? How much can I improve my health? The truth is, very few women will come and say the driver was, I want to lose weight. That's not usually the starting point. It's something that has happened that has led them to think it is my weight that is the problem. So if you yourself sort of dig into what that why is, so someone, I've been diagnosed with hypertension, I've been diagnosed with type 2 diabetes, or I'm pre-diabetic, I've turned 40. I've had my 40 plus health check, and they've told me this, that, and I'm worried, am I going to be okay if I don't sort this out? Or like you're saying, someone called me Gogo, Ambuya, or whatever, and stuff like that. It really hurt my feelings. Or I went into my wardrobe and I walked in and I couldn't find anything to wear on that day.
Yeah.
I'm having, I was invited to an event and I realized I couldn't fit into anything. So the questions then would be, you want to know what approaches can be useful for you, what's sustainable for you. I think people forget, because they're so in such a hurry to get to the point where they feel, if I lose this weight, I'll be okay. They forget to think about sustainability of their efforts.
Yeah.
So we spoke, I think, at the beginning about obesity being a chronic disease. So you will never be cured of obesity. Okay, so what we can then do is control it, try and manage it. So what I want you to always carry in your mind is, this is something that I will need to do for a long time. So we spoke a bit as well about when we had the conversation about things that we would rather not hear about again. So every diet works. It will help you lose weight, but the question is, how long can you sustain it?
Sustainability.
And how healthy, and how do you feel after that diet? So if you decide to go on a keto diet, for example, you're cutting out carbs and you're eating all this, you will lose weight, but how sustainable is it? And that's what we want to look at. That's why I think this method, in terms of giving people what they like to eat, working around each person's, people say, oh, you know what, I love eating sadza. How could I possibly lose weight? Of course you can lose weight eating sadza. It's just how you pair it, how much sadza you're eating, what you pair it with, and all those things. What else are you putting into your diet, and all those things. So which we can look at.
Yeah. Okay. I think I love the issue around sustainability and working with what you like eating. I mean, like, when you're over 40, and getting to 50, like some of us, you're like, I just want to have a good life. Why am I now sticking to, things that I don't like eating? I like eating what I like eating. So how do I incorporate that into my diet? So now let's just talk about who gets medication or bariatric surgery, for instance. Why might women with weight concerns not qualify for medication or surgery, even if they feel they need it?
So we spoke about all these assessments that we're doing. This is also something, obviously, as a doctor, I've got at the back of my mind. I'm trying to come up with a plan. What works for this patient? What can we offer this patient? So, and then we also have guidelines that we all governed by for obviously safety, based on safety and results. So we've got measures in terms of body composition, where we say women of a certain BMI. So that's where the BMI comes into play. For example, we're not using it as a tool to punish women, but it's a tool to almost guide our treatment, when to start treatment, when to change treatment, when to pause treatment, or whether to say treatment is working. So that's one place. So one area of starting. So for example, we've got higher sort of thresholds for bariatric surgery compared to the medications, for obvious reasons. So then you're looking at if we want to start the weight loss medications, we're looking for a person who is obese, for example, so a BMI of over 30, we can say definitely let's start looking and thinking, can we use medication there? For lower BMI, say maybe BMIs of 27 and above, so between 27 and 30, if you've got a medical condition that comes with that, for example, hypertension, diabetes, hypercholesterolemia, all those sort of things, we then think we can treat you at a lower BMI, because you're already suffering medical consequences of weight gain. So a person with a low BMI, so BMI under 26, for example, will most likely not qualify for medication. But we're not saying that your concerns that my weight is not where I'm comfortable with are not heard. We will hear them, and we will say we've got other alternatives that we think we can look at. which are not medication or certainly not surgery, and then we can explore those. But sorry, just a side thing on that, I don't believe people should get a prescription or surgery right off the first assessment.
Yeah.
Because so we're talking about sustainability, we're talking about understanding and assessing. We haven't finished assessing you at the end of the first consultation. So there's another thing I was saying you need to don't expect to walk out with a prescription. You're likely not going to walk out with a prescription. You're going to walk out with a plan for things to do, not a prescription. So, and then also part of that assessment, we spoke about medical history. So there are certain medical conditions that would not align with using medication, for example, or even surgery. And then we spoke about your menstrual pregnancy and all that history. A woman who's trying to get pregnant, for example, or who is pregnant or breastfeeding is not a good candidate for medication or surgery, for example. Then there's certain conditions, certain types of endocrine tumors, for example, that would preclude use of certain medications. So we then say, okay, because of this medication or that medication, and then in certain cases, certain levels of mental health disorder, we say, okay, probably not the best person to be going through surgery or medication, and so forth and so forth. And then also, we find that a lot of these treatments are self-funded. So you've got to keep in mind, we spoke about financial considerations. We can't just be prescribing to people because they want it or because we're thinking of sustainability, understanding that, for example, if you start weight loss medication, we're not giving it to you for a month or 12 weeks and say, oh, everything's great. We're looking at it as long-term chronic medication. So we all want to sort of imagine that, how do we make this work?
Yeah.
And then also the timing of treatment means that you might not get a prescription at that point because it's not the right time for you. Maybe we do need to effectively deal with your diet. So I always tell people that, weight loss medication, for example, what the GLP-1, for example, we spoke about great length, it reduces your appetite. So you're just eating less of the rubbish that you're eating now if we don't deal with it. You will lose weight, but you will not have great health outcomes. So so there's all those things, all those reasons why you might not get a prescription.
Yeah. So how do we then look at the other conditions like your thyroid disease, GI issues? You talked about mental health, and how do these affect your prescribing decisions? Because sometimes also there's an issue that comes in terms of cost and accessibility. Here in South Africa, we've heard a lot about compounding of GLP-1 medication. It's really bad. So what does that look like for me? I'm in a consultation. How do I know that this is the issues are my thyroid, GI, anything like that? And of course, how do I know that whatever I'm prescribed is actually correct, and is appropriate for me?
Okay, so we spoke about this partnership and focus being you. I'm assuming by the time you get to a prescription, which is probably on your second or third or fourth or even later down contact with this institution that's doing your treatment, you have also had a chance to assess them. You also had a chance to interact with them. And then we also, so for example, for my practice, we give a consent form. We send out a very extensive consent form for treatment with medication. So we don't do bariatric surgery, but we do bariatric medications. So we send out quite a very extensive consent form. In that consent form, we give you information again about how these medications work, what they can realistically do, what your role in making this treatment work. Remember that partnership, I believe it's a partnership. You also have a role to play for this to work. It's not, oh, you just get a prescription, everything just fits into place. You've got things that you're expected to do as well. And then what our expectation as your clinical team, what we're expected to offer you. So everybody sort of knows what to expect. And then in terms of you asked about other conditions and how that, how is it a safe prescription for you? We spoke about quite an extensive assessment. So these are the things that we are also looking at. I mentioned a few things along the way that would preclude me from giving these medications to a person, for example. So in doing the blood tests we also assess thyroid, not only just to see if the medications work, but then because sometimes some thyroid conditions can affect your weight. We also do a metabolic profile, so we also want to look at things like your sugar, your blood, your body's management of sugars. So we do HbA1cs, for example, to try and see where you are in terms of the diabetes scale. Are you pre-diabetic? Are you not? Are you diabetic? Because then that also affects what other medications we want to give you, what we can give you, and what so if, for example, if you look at pre-diabetes and insulin insensitivity, for example, it affects our weight gain and all those things. So these are all things that come together. So in that assessment, we're trying to find where you are on the grand scale of health. So it's, which again comes back to the point of, it's not about the scale.
Yeah. So now we're in perimenopause. Where does hormonal therapy come in now? What do I do? And do you think then do you as a bariatric physician prescribe hormone therapy, or now I have to go to another doctor to get it done? Can I just have it all done at once?
Okay, so there's certain things we can help with. Then there's also certain situations which I think require a more specialist approach, where we would need assistance of say a gynecologist or a GP who's got special training in that. So we do have colleagues that we work. So even for example, I spoke about mental health and all those. We work with mental health professionals. We work with gynecologists, obstetricians. So sometimes people come to you because they're struggling to conceive, for example, or they're trying to conceive. So we work together to do that. Or they've come to you because, they've got their joint pain. They feel that losing their weight will help. We also can sometimes refer to a rheumatologist or orthopedics, depending. Also, there's room for, again, partnerships, not just with the clinical team that you've got in front of you to prescribe your weight management, whatever, but then other specialists that we can help work with. So yes, there's certain things we can prescribe. So what we can do is have an assessment as a start and say, okay, likely we think this is probably along the lines of perimenopause and menopausal concerns. We're not going to say we can't treat you. We talk about all those things, and not every woman wants hormone therapy, for example. They want to try other things, but sometimes in improving your movement, improving your weight, improving your blood pressure, and all those things, it tends to lift some of the symptoms of perimenopause. So it's a fine balance depending on the woman's desires and preferences, and obviously the clinical picture on the table. So I don't know if that answers. I hope that sort of touches. It's not an easy
because it's not one size fits all anyway. So now let's talk about accountability. How often do you see me now, when in your rooms? Because you said you see me often in the beginning, and maybe I'm eating whatever I'm not supposed to eat, or what we've agreed, our shared decision making. We've done it nicely in a consulting room. But when I'm home, things go pear-shaped and I'm doing whatever I want to do. Accountability, and how often do we come together and just look at?
The first thing I always tell my patients is, please understand, prepare to either get sick of me or you're going to be my best friend.
Okay.
So and usually I think just look at it. So there's no, you said I've eaten things I'm not supposed to eat. There's no such thing as things that you're not supposed to. What you find is in that understanding yourself. So you talk about the perimenopause, for example, your PMS symptoms are a lot more voracious in the perimenopause. So you think about, for example, those cravings that people get, it becomes a really big thing, for example, and then, oh, you know what, I just wanted to eat all this sugar. Okay, let's deal with that. It's not a disaster. This is what happened. How can we manage it better? Because sometimes, yes, so how can we're not saying don't eat it, but then how, for example, someone realized, okay, you know what, if I don't have all these things in my house, and when I do want it, I'll just go and buy what I want. I want a bar of chocolate. I'll go and buy a bar of chocolate and move on. So what is a bar of chocolate in the grand scheme of things? Nothing.
Mm-hmm.
A slice of cake. I went for a coffee, I had a slice of cake. Yeah. But the thing is, you're aware of what it is that you're actually eating.
Yeah.
So you're asking, how often do you see me? So obviously, I think as we're doing so the first consultation, and then obviously sometimes we've had some tests sent out, for example, which will warrant another conversation. And then we're also doing the assessment, the nutritional assessment, the journal and all that. So it might be certainly after the first full week of journal, we do need to catch up as we start making plans. And maybe, you know what, for the next week, this is what I would like you to work on. And we catch up again. So it might be week. I think it's certainly weekly I encourage weekly for at least the first 12 to 16 weeks, depending on how this person is doing. And then some people need a weekly for the rest of their treatment. Then at some point, for some people, it clicks. And then after a while, we then switch to maybe, okay, you know what, let's do it twice a month. Let's do every third week. Let's do this. Let's do that. Or then something comes up, you know, oh, this has happened. Or sometimes people on their medications as well. If someone eventually starts medication, we also want to follow them up a bit more frequently at the start as they get settled and as we increase their doses and all those things. So it's not a one side. There's no like, oh, but like I said, all I can say is at the start, certainly I would say expect to see us weekly for a bit. But then this is virtual and people don't really struggle to make the appointments. If anything, people are quite relaxed about it because they can be wherever they are, which is the beauty we have. I found, you know, I used to work in a physical clinic, but the move to a virtual clinic has improved attendances to our, especially follow-up appointments, to infinity, because people can manage their time a bit better around, you know, I need to dedicate 30, 40 an hour, not 2-3 hours, because then I need to commute to wherever it is. I need to go think about parking. I need to then whatever. So it's just, you know what, I'm in my house or I'm in my office. I've got a quiet time. I can give you the time. So, and then move on with and get on with the rest of your day. So,
okay. So maybe you just dwell a little bit on this first consultation online, you know, virtual, because we're expecting you to come with a tape measure and measure my waist.
So we give you a nice little preparation. So we send out a nice little, like I say, we've got consent forms for all sorts of things. We've got a little how to prepare for your appointment, because a lot of people are experiencing virtual consultations maybe for the first time and don't know what to expect. And they think, oh my gosh, it's going to be oh, I need to, but come as you are, all relaxed, whatever it is. But it's a conversation like you and me are having a nice conversation virtually like this. And people actually, I've found people a lot more relaxed when they're in their own setup. They're dressed how they want to dress. They're set. Okay, the only thing I do obviously is advocate for is please be dressed.
No nakedness. Yeah, okay.
Dress however they want. Some will come, no wigs, no nothing. They're sorted, and then so we also give them a list of things to prepare. So, and then some we can send out for certain patients if they can't get all these things together. So obviously we want to monitor your blood pressure, your measuring tape, we need scales, your height and that sort of thing. And then depending on what we're dealing with, some patients locally to where I am, I mean in the UK, we can send out so things to sort of measure your ECG remotely. We can send out a digital stethoscope, for example. If we feel we really do need to listen to your heart, we can send out a digital stethoscope, so it just takes a recording of the heart sounds and everything, and we do the analysis in clinic. And then we also have blood pressure monitors and scales and digital scales that we have that are monitored digitally if you're that way inclined. For our more tech savvy patients, I like those. And then the beauty of it also is people have their movement trackers. A lot of people wearing a movement tracker, so they just share. A lot of them give you a nice analysis. So that's part of the journal. One of the journals we do is a movement journal. And then if they like, also we can provide activity trackers and all those things. So there's all these things that we can do remotely. And then even our blood work. So locally where I am, we send out a nice little package. We do microcapillary testing, so tiny little tubes that you can do a finger prick, and we do whole panels, complete panels from there. And then you also have access to a digital portal where you can look at your results as and when you like as well. And it comes with advice and explanations on the blood test that we do. So it's really comprehensive. So my desire is that when we talk about this focus, I want, as people move into these adult ages, have more control and more information, and so that it's not meant to scare you. Says, oh, I don't like you. Oh, they just did some blood tests. I went to the doctor and they did some blood tests. Okay, this is information about you and your health. And there's ways this information can be, palatable to you, and it can be explained to you. Also understand that when you come for a consultation and you're told, oh, we've got your results and this is what we found, it's a lot going on in that 30-40 minutes. You will not obviously always put it to memory.
Yeah.
So the nice thing about virtual consults also as well is we can send messages back and forth. You can ask questions afterwards. You've got access to these results and then explain, oh, you know what, I forgot to ask this. Is this okay? This is what I found. Is this okay? You know what, I didn't have access to all my medications when we spoke that time. Here's a picture of my medications. This is how long I've been taking them. Oh, here's my period tracker information. So, I mean, it's amazing. There's so much, you can get to really, really get into the core of your patient concerns.
Yeah. So what does it mean for someone who's in Zimbabwe, someone who's in South Africa, someone who's in Kenya, who's everywhere else in the world? What can they do? Can they consult with you?
Yes, they can. So, all these things that we've discussed are available to you where you are. So you can get a blood pressure monitor. Everyone can get a blood pressure monitor if you need be. If we need to have one delivered to you, we can have one that delivered to you. You've got this is on you already and stuff like that and so forth. So, and then for certain countries, we can partner with certain labs. It might not be a kit to your house, but it can be a lab close to you or truly speaking, there's many ways around it where we can get your bloods done. And then we do the same process. So, and then in terms of the other specialists that we're working with and other professionals we're working with, it's also a virtual consultation through the same portal. So,
okay, this is where we are moving to, guys.
Yeah.
In terms of consultations, and everything can be done in the comfort of your own home, and I love it. So now let's talk about what happens after your after GLP-1. Is there an after the GLP-1 medications? Is there, even after your bariatric surgery? What does that mean? Can I stop? Can I continue? How do I maintain?
So absolutely. Well, you can't stop after bariatric surgery. It's done. The surgery is done. It's done.
Yes. Yeah. How do
And
we
then
maintain?
in terms of medication, yes, you can stop. People sometimes get to a point where, like, okay, I want to stop. And then they think it's a conversation to have. Remember that initial consultation we discussed, that is the time we start building the foundation. So all these things that we're doing, assessing your eating habits, your movement habits, your hormonal profile, psychological profile, all these things are to help you to develop what we call lifestyle changes. So, and as I mentioned, we don't start you on medication immediately anyway, because we want to establish this baseline so that so sometimes we realize then after everything, we can't use medication, but of course there's a lot we can fix. There's a lot we can work on, and we'll continue working on those things. And then as we also now we realize weight, so the weight loss pattern clinically obviously changes depending on where you are on the process. So at the beginning, people are losing weight rapidly and all those things, and we're also monitoring how rapidly you're losing that weight. We might want to slow down. We might want to, we are watching how you're eating still at that point. What's happening with your protein intake, for example? Are we losing too much muscle? Are you moving enough to keep, things going? And then as we get closer and closer to where we would like to be in terms of targets, we want to this is where we're also ramping our movement prescriptions, and which then helps us. So your muscle mass, your movement, and all those things, and your eating habits is what helps you to maintain your weight. But then at the end of the day, obviously, we're using appetite suppressants, or we've done surgery to bypass absorption and all those things. So if we stop, obviously your appetite does come back somewhat, but this is something you're prepared for, because hopefully we've managed to instill some good habits before you started the medication. So, and I always say the medication is a tool. It's not the pillar of our treatment. So weight loss management, medical weight loss management existed way before GLP-1s, and we've just been added another tool.
Oh, yeah, it's so good to look at it that way, because there've been a lot of things, and we tend to punish ourselves as women. I think what's important, like what I'm taking from all this, is that you are now aware, or you are aware of what to eat, what to do. Don't punish yourself and think that you are a bad person, but let's see how we can rectify some of these habits that we've got. So what happens if you regain the weight? You stop.
What I always tell is, I don't want people to wait until they've gained the 40 kilograms back. So while you're still, so we also do catch-ups with our patients, depending on how, like, if say they stopped medication, for example. Sometimes at the beginning, we're doing it a bit more frequently again, after they stopped, see how they're coping. What's happened to and then sometimes we go back to the food journal just so we can see what's happening. Are you eating enough? Because sometimes then people think, oh, I need to restrict, I need to whatever. Are you eating too much? Are you eating the right things still? Are you staying true to your new habits? And then most importantly, let's see your movement prescription and all those. And then we then start, oh, you know what, I'm a bit worried. You've gained this much weight in the last 4 weeks, in the last 8 weeks. What can we do? How can we claw things back? So sometimes it might be, let's adjust this, let's adjust that. And sometimes it's, oh, you know what, I want to go back on the medication. I think I'll go back on the medication, which is sometimes what people do. And then with regards to the bariatric patients, some weight regain does happen. Also, again, as people's habits, it all comes back to habits. And so at least for the bariatric patients, some of them that qualify, we can put them on medication, for example. So I have a number of patients who've had surgery who are now on weight management medication. Or sometimes it's, you know what, I think let's have a conversation with the psychologist. I think this is where we are. Because sometimes, you'd be surprised also how we spoke about how people's weight affects them emotionally and psychologically, but then sometimes we attach our personality to this weight. We've had this weight for so many years, and this is the person that you've sussed yourself out. You know how to fit yourself into the world. You know how the world acts around you at that particular weight. And then when people lose their weight, sometimes they lose themselves. They lose their drive. They lose sense of who they are. So who am I now? Do I need to dress differently? Do I need to be a new personality type? Do I need to be this? So sometimes we also need psychological support, and that sort of helps to even things out. And then there's certain things that will need support anyway along the way. Sometimes people maybe have other eating disorders that we need to deal with. So these are all things that we can consolidate.
I think so. I think it's nice that you're talking about everything and what is expected during a consultation, because we rarely think you go deep like this. We're so used to just getting a prescription written and goodbye. We'll see you here. Here's your medication. We'll see you after a month. Yet it's actually more intensive than we think. And the support, again, remember what I was talking about in the beginning about friendships, and you now talked about partnerships. That is very important, because it becomes the pillar and the anchor for yourself as you've changed habits, and now you're a new you. What does this mean? I'm now a size 10. I was a size 20 or 22. What does this look like? How do people look at me? Do they know that I'm actually using medication, or I've had surgery? How do I navigate that space?
That's another really big one, actually, that so you talk about prescriptions. Sometimes another reason why you wouldn't reach out for a prescription is if a person is conflicted about using medication, for example, so all these opinions and all these stigma, and I don't know why. I mean, it's just a drug like any other, but we all know that's happened. I think we had a nice big conversation about GLP-1s and their stigma and stuff like that. But sometimes if a person is really on the fence, I'm very reticent to start them on medication until we've dealt with that. I think we'll find other alternatives for such people until they're totally convinced that's what they want to do, because that will affect compliance, and then even the results they get, or even the understanding of what these drugs actually do, what side people have been told is all these side effects and whatever. And like I've said, I've never stopped a person medication because of side effects, because if you are being followed up, obviously all this is being managed and anticipated and dealt with appropriately.
So maybe we are going to the wrong people. Maybe we should come to you for management, So anyway, now let's look at the African context. We are African. We've got our bodies, we've got our genetics, and also we've got our culture. So how do cultural norms, stigma, we've talked about stigma, and expectations shape consultations for African women? Do you shape it differently? Do you put in certain things to consider when you know that this is an African woman? Be it you're in the UK, Australia, America, wherever, you're still an African woman.
Actually, I think you've touched on a very nice point by asking if a woman is in Africa, Australia, UK, or whatever. So where this African woman is located, where they're living their life, is also quite important. It's a big consideration in how they perceive their weight, they perceive their efforts, the tools that are available to them, the foods that are available to them, what the society around them expects them to look like, what their husbands expect them to look like, what the families around them, and whatever their support structures also. So all this comes onto this woman. So in the context of, then there's things that obviously travel with us regardless of where you are. So if we're talking about an African woman, for example, so we've got African women in the sense of they are African, they live in Africa, they've lived in Africa, they identify as an African. We've got African women by genetics, so women of African origin who cannot run away from their genetics, regardless of however they identify themselves. I'm a European or I'm American or whatever, which is still a woman of African origin. And then you've got the African woman born of African parentage, but probably not lived in Africa. These are all very distinct. So, and I'm sure there's a few other subgroupings in there that we can consider. So this has an impact on the food environment that they have. So how they what they would like to eat, what they enjoy eating, what they think they should enjoy eating can be also different from what they like to eat. For example, we spoke about sadza, I don't know, shima, pap, depending wherever you are. I think for our West African friends, they've got their fufus and swallow, whatever version they have, and all those things. It's the same conversation across all African women, where a lot of them enjoy this food. We like eating it, but we've been told if you want to lose weight, you can't eat that. You've got to just eat salad. You've got to eat, you must like, certain exotic fish. You must do this. You can go plant-based. You go, and even when we talk about plant-based, what we also don't realize, especially in sub-Saharan Africa, that our diet is essentially vegan on the whole. When if you think about it, you're eating sadza, you're eating, some vegetable with that. Whatever vegetable varieties you're having, and then there's so many with peanut butter, with ground nuts, with all sorts of these other, so there's the backbone of our sub-Saharan diet is vegan. So when people now talk, they're all being fancy about it, but have you made beans? You're eating beans with your vegetables, with your sadza. That was completely vegan.
Okay. All right. I hope the ladies are
eating. This is everyday eating. So it's nothing new. It's nothing exotic. This is the backbone of our diet. Meat is not something that we eat often traditionally. Now people believe, okay, because I'm now economically upwardly mobile or whatever it is, I need to have meat all the time. I need to fry my food. So you look at a Zimbabwean diet, for example, cooking oil and all those things are not part of our diet. We boil a lot of our food. We roast a lot of our food. We dry a lot of our food. And that is low in saturated fats. That's all. It's actually a really good diet.
Okay, all right.
But
But
but because we are meant to, we then look at this diet as, oh, this is economically depressing diet, so I can't be enjoying such things. Really, I should be eating particular things. And again, there's nothing wrong with that, but I'm just saying, again, we can lean heavily on what we are used to cooking, what we've learned, what we grew up eating, which can be a source of comfort to a lot of people. People think, what, oh, sadza chicken, I feel comforted after a long day, and there's nothing wrong with that.
yeah. Okay.
So we
Yeah.
then work around how to make that sustainable. And then in terms of how they perceive themselves, so we look at how bodies are perceived. Expect a mother to look a particular way, a young woman to look a particular way, a go-go, for example, to look a particular way. And that's just how our society is, and because that's what's around us. But then you move these people into a world now that's more global. So we're all we've got access to everything else. That's the way everybody else is looking, and what's hot and what's not. Everybody's getting a BBL, everybody's doing this, everybody wants to look. So we had the curvaceous bodies and all that led up to this from where. But now I think people are now reverting back to the super skinny type bodies that, so where do you fit in? How do you fluctuate with all that? And then you've got, certain African men would like to see their women looking a particular type of voluptuous. But our families and friends, you lose a certain amount of weight. Are you okay? Is everything okay? So then the African woman, unfortunately, is caught in this web of all these expectations. And then the last one of it is her own. So we come back to the focus. And then sometimes she knows what she wants to look like, but how does she sell it to everybody around them? So there's a lot that comes in with all that, and then losing themselves in all this.
In all the mix of it, So why do African women often feel dismissed or unheard when discussing weight in clinical settings? Why do we feel like we're not heard? Or is it because we're not vocal, we're not advocating for ourselves? So how do we also advocate for ourselves?
Let's start with that. African women are unlikely to show up to a clinical setting to find help with their weight. They will talk to their friends, they will talk to that one, they'll read online, oh, I heard there's this, I heard that there's that, and they'll just do what they can at their house. Oh, I heard there's Kakito, there's Cambridge, there's Juice Fast, there's this, and they'll just do it. It's fasting. Oh, I just need to exercise. I think traditionally it's not something that we've associated with the medical setting, that there's actually, this is a medical problem. And it's not just African women. In all fairness, I think I would not like to saddle African women particularly with this one. I think people in general have not understood that obesity is a medical condition, and they've got the right to demand proper, registered, monitored medical care for that. So in the same way that they would ask for treatment for anything else, they can for their weight. So, and then there's also the idea that sometimes people are told, you then go to the doctor for other reasons, and then the doctor then tells you, you need to lose weight to deal with your sore knee. You need to lose weight so that we can manage your blood pressure better. You need to do all this. So then also that they're dismissed when they're talking about their real concerns about what's hurting, what's aching, because it's all just being associated to you being a particular size. You need to lose weight. I told you need to lose weight. I need to lose weight. So that's another reason that contributes to them feeling dismissed. So, do I have an answer? Probably not a straightforward answer, because again, bariatric physicians and all those are not that abundant, and then again, it's not a typical focus of medical training for all doctors how to deal with this, because we're also coming from a point where we are also just only beginning to accept globally that this is a medical problem.
I would really want you just to sum it up for us. Everything we've talked about, weight management in perimenopause, menopause, and just say what you feel you want to tell women out there.
So I will start on, it's okay to focus on ourselves. It's not something that's encouraged. Traditionally, you are worrying about everyone else. I think this is that time in your life where you can take a little pause. The children are a little bit older, the demands are a little bit less, your career is on a nice little sail, perhaps. I hope you've settled in your whoever you are, the relationships around you, and you can you're a bit more discerning about the things that are important to you. And I think our health at this point then becomes also a big part of it. So in terms of perimenopause and weight gain and weight management and all that, that sort of comes together as a tidy little package, and just dealing with it as a holistic concern, it touches on all these areas. When you even talk about if you decide, you know what, I want to deal with my perimenopause, you'll realize that a consultation for perimenopause will touch on a lot of the things that we were discussing. In terms of weight management consultation, for example, and feel free to ask for what you need, but also ask yourself, what is it that you want to get out of it, achieve out of it, and understand that it's not a 2-week process. It's something that you're making changes for to improve the rest of your journey on this. You want to be healthy for as long as possible and to enjoy it. You find then a lot of women in this age telling they're in the best shape they've been in their lives because they've got time to dedicate to themselves. They are doing it just for themselves. They're exercising for themselves. They're there, you see them, they're doing their strength training, they're doing all these things. And we come back to the point of grace, because then you also think, you know what, I want to do it. I've seen that 50-year-old woman, hey, she's got abs, like, hey. You want to do everything, and you've got to give yourself grace. Take it easy. Enumerate all your concerns. What are you trying to do? I want to improve my blood pressure. I want to improve my skin. I want to improve my sleep. I want to do this. I want to do that. And then also then, in the same way that you're making conscious choices about the things that you are eating, how you're dressing, we're not just picking up, be also discerning about who you go to for your help. You can't be taking advice about your health from the lady at the salon. You've got to, this is a medical concern, you've got to go to the right place. You're not going to ask her about your gallstones. You will go to your general surgeon about your gallstones. So go to your physician, whoever it is that you need to discuss your weight concerns, your perimenopause, your menopause concerns, and all those things, and approach it in a sober manner and try to find a sustainable solution. I think sustainability. So my words: grace, focus on yourself, sustainability, and please feel free to speak for yourself and ask questions. Get all the information that is out there about yourself in a way that you can understand and make use of it.
So I see there's a question, I think it's Rua who said, what are the factors that are taken into consideration when looking at BMI, especially regarding muscle mass, ethnicity, body fat percentage, and body shapes, and how they influence the BMI? So one might have a high BMI, however, the body distribution are at play. How does that all come together?
So that's a nice big topic, something we're constantly trying to improve in the field. So BMI is a universally acceptable metric. So it's just essentially measuring your waist and then your height and that sort of thing. So it doesn't take into consideration your body distribution. It doesn't take into consideration your ethnicity. It doesn't take into consideration your general health outcomes and your blood pressure and all those things that matter, your muscle mass, etc. So which is then we then have things like people who are high BMI who are healthy, or low BMI who are not healthy. So we've got different variants in there because of that. So we've introduced other things along the way, and they're constantly being reviewed to try and improve that. So when we look at an assessment, we're not looking at just BMI. It's not just going to be that thing. So we also have, so the idea is how much weight, fat are you carrying around your organs, which is what really makes a difference to your metabolic profile. So what we call visceral fat. So if you've seen online sometimes when they do what it called DEXA scans, where they light up, you got all this yellow around your heart, your stomach, and all those areas. We want to always reduce that. So we want to quantify that and reduce it. So we're now looking for ways to measure that. So we can there's clinical measurements we can take. So things like your waist and height ratio. We can also do just your waist and hip circumference, for example, and then we can do your upper arm measure, but not so much. But these are all things that sort of add on to that. Sometimes we can do the upper back fat measurements, fat pad, and then we can then go into more technical body composition analysis. So you can do, there's MRIs that you can do, there's where you use electrical conduction through the body to measure all that. So what we call, so there's many things that we can do to get a proper assessment. But we realize that for clinical purposes, we don't need to know all those things to particular levels unless there's something going on particular that we'd like to monitor. So for most people, we are able to manage between, measuring their weight and doing all those ratios that we discussed, measuring their waist circumference and hip circumference, and then we do the bloods and all that also gives us a good idea of the metabolic profile. We do blood pressure, heart rate, and all those things. So a combination of all those things, and then we can obviously see body distribution. We can also see your ethnicity. That helps us to, if say a person of Asian origin, certain Asian origins, we're then thinking, okay, maybe at a lower BMI, I should be a bit more concerned because of the high rate of this. And then African women are more likely to carry weight in certain areas, depending on what part of Africa they're from. Again, it's not just one demographic, these African women. So what you're seeing, what you're hearing, all that we're measuring, the bloods, everything, it all comes together.
Holistic approach. That's what we wanna really push around here. So I think, you summed it up, and your keywords again, the grace and sustainability, and I think also the awareness of what this means for us at this age is very important. That's where I come in, because I really advocate for wellness, because sometimes we, as I said, we punish ourselves for no reason. We just have to move with the flow, enjoy ourselves as we get older, take time to really think about what we want and where we want to go to, because it's a lot. We've come to the end of our session. So thank you, ladies.
Thank you for your time. Thank you